he is one of the active and most beloved professors in his faculty among his students. So we are welcoming him with us today.
Thank you so much, sir, for this introduction. I'm honored with this kind introduction. Today I'm going to present the fetal echo, and I said made easy to approach it in a simpler way. We know that the abnormalities of the heart and arterial trunks, they cascade in families. So if you have a baby was born with a congenital heart problem, the coming baby is at risk, and if the mother is having a congenital heart disease, her baby might be at risk with a ratio of 1 to 10 to 1 to 20. So there is a high possibility that it cascades in families. So we have indications to do the fetal echo, maternal indications and fetal indications. Definitely maternal indications if you have familial inherited disorders, teratogen exposure, positive consanguinity, IVF, these are the indications for it. While fetal indications, if you have increased nuchal translucency, first degree relative of a fetus with congenital heart disease like a father or mother, abnormal cardiac screening testing, and extracardiac anomaly. The ideal time to do the fetal echo is between the 18 and 22 weeks of gestation. Beyond that, the body mass index of the baby to the amniotic fluid is large, and even the calcifications of the ribs and sternum, it might cascade a shadow on the heart, compromising the viewing. And in the early examination, the baby is very small in mass index, so that's why we use the transvaginal route to be close to the heart and magnify it as much as possible. Look at image number 8. There is the shadow of the vertebrae shading on the heart, compromising the view. That's why it's better if we can tilt our probe to acquire a clearer image of the heart without this shadow of the vertebrae on it. Fetal heartbeats, we know that it ranges from 110 to 160 beats per minute. So before starting and looking for the congenital problem, look at the heartbeats. There is no heartbeats in these babies, even using the color Doppler. So we have an intrauterine fetal death. So we can predict what we will see later when we do the scanning of the heart and the whole baby. Systematic approach, we need to be oriented and knowing the 4 chambers view, check for the situs, evaluate the size of the chambers, evaluate the size of the whole heart, check mediastinal shift, check the cardiac axis, LVOT, left ventricular outflow tract, right outflow tract, assess the 5 chambers view and the 3 vessels view. This is the imaging technique. We start caudocranial from downwards, starting with the gastric bubble, then escalating up till we get the 4 chambers view, then the 5 chambers view having the ascending aorta in between, then the outflow tracts, and finally the 3 vessels view that we acquire with the trachea. Orientation of the heart. I placed this as it's from the literature. It's a bit conflicting. I don't know whether the baby is a pre-breech position, so the hand would be, that would be the right side and that would be the left side, or cephalic and opposing the directions. So in order not to be biased with the cardiac position to know the heart and evaluate it properly, we can use and rely on the normal anatomy that we have. Is that we have the spine, which is echogenic here. In front of the spine, there will be the aorta. In front of the aorta, immediately adjacent to it, the left atrium, left ventricle, right atrium. So regardless the position of the baby, I can rely on the vertebrae and the aorta to know the chambers of the heart. And if we use it in the motion movement, definitely again, aorta, left atrium, right atrium, aorta, left atrium, right atrium. So we can easily plot the chambers of the heart regardless the position of the baby. There is an abnormal 4-chamber view. We don't see the 2 ventricles and 2 atria. That's the aorta. So that's a monoatrium and monoventricle, and there is ventricular hypertrophy with a congenital problem with the heart. The situs soleus, that's the normal situs. I said that we start caudocranial, so there's the stomach there, and we sweep up cranially till we reach the apex of the heart, and it's supposed to be having the apex directed toward the stomach on the left side. So if we use the video images, that's the apex, and that's the stomach, that's normal. But look here, the apex is down there, and the stomach is on the other side, so that's a dextrocardia. And here is an illustration of a twins case. The apex is down there, and the stomach is up there, so definitely we have a dextrocardia problem. And she aborted the twins, by the way, having other malformalities. The axis of the heart, if we draw a longitudinal line from the vertebrae to the sternum, the axis should be oriented 45 degrees on the left side, as we see here. Abnormal positions of the heart, we have a mesocardia, where the apex is directed in the front midline behind the sternum, or a dextrocardia on the opposite side. The chamber size and the heart size. Usually, both ventricles should be equivalent in dimension if we take the transverse plane. By the way, we always rely on the 4 chambers view. That's the initial start of the heart. So both ventricles should be the same, but the right atrium could be a little bit larger than the left one. That's not a pathology. Even the atrial septum could be deviated a little bit. That's very, very normal. How to acquire it? By bringing the 4 chambers view, measuring both transverse ventricular dimensions below the cusps, and taking the whole transverse diameter of the heart, then finally taking the thoracic ratio and doing the cardiothoracic ratio, where the heart is 1/3 of the thoracic dimension. And even we can take it via a circumference of the heart to the circumference of the chest, but usually we prefer the classical way. Heart displacement. I said before that the aorta, immediately adjacent to it is the left atrium. But where is the aorta here? That's the vertebrae, the aorta, and the left atrium is completely displaced anteriorly. So when we have an isoechoic lesion, like that one, a mediastinal lesion or a chest lesion, it can cause displacement of the heart. So if we're acquainted with the normal appearance, we'll definitely can spot or suspect that we have a mediastinal problem shifting the heart. The 5 chambers view, again, I said it's not an extra finding. They are the atria and the ventricles and the aorta ascending from its origin, doing an extra chamber. Let's go for the outflow tracts. We said that we sweep codocranial with a slight inclination of the probe to the left side. Let's see what will happen. The left ventricular, we said that that's the aorta, so that's the left atrium, and that's the left ventricle. So the thing arising from the left ventricle here would be the aorta, right? So it's like a ballerina's foot. If we can take this appearance, there is the foot, and there is the leg, and that's a diagrammatic illustration of it, like a foot and the leg. So that's the left ventricular outflow tract. What about the right? We all know that the right ascends from the right ventricle, the pulmonary, with its divisions. So it's very clear that we have the LRVOT, and that's even a diagrammatic illustration. And by the way, we have the pulmonary artery, aorta, and superior vena cava, PAARS. So they are descending manner in their transverse dimension. The pulmonary should be larger, the aorta smaller, and the superior vena cava the smallest. By the way, let's take a quick glance. That's the left ventricular outflow tract. So it happens in fractions of seconds. Left, and that would be the right. Left, and that would be the right. So we need to train our eyes not to be compromised, because here we're placing a slow motion video. But in practice, it's very quickly, so we need to be acquainted with the contractility of the heart. Again, I said that we have a 3 vessels view, the pulmonary artery, aorta, and superior vena cava. We have them here. And by the way, that's the ductus arteriosus. So we have here the pulmonary is wider, aorta less, and superior vena cava the least. That's the V-shape appearance of the ductus arteriosus. And I personally must place this image on all my scans, showing this characteristic V appearance between junction here. That's for the ductus arteriosus. Additional views of the heart, that's the aortic arch in a sagittal plane, where we have the vertebrae, and it's like a candlestick with branching arising to the neck, and the ductus venosus that we just heard about. It's like a hockey stick extending from the umbilical or from the abdomen level and pushed backwards as if it's like a hockey stick, and we can plot it. Common congenital heart problems, definitely I will not go in details with the ASD. We have ostium secundum and ostium primum, which defect in the upper membrane or the lower aspect of the membrane near the ventricles. And here we have the ventricular septal defect. It's very clear that there is a defect, but in some cases I might be confused, so that's why I prefer using the color Doppler to show this characteristic edge appearance, making us be confident that we have a VSD. And that's very important finding, by the way. Here we have AVSD. Definitely it's not just a ventricular septal defect or atrial septal defect, or the chambers are open together. By the way, that's overriding of the aorta. When I see a VSD, I must look for an overriding aorta, where the aorta is positioned on top of this VSD, not arising from the left ventricle solely. And you can see here in the slow motion video that the ventricles are here, and they're giving a Y appearance of the overriding aorta. Here it's very quick, but when you see the ventricles, and that's the aorta, and I zoomed in with the finding, the ventricles and the aorta coming like a Y-shaped appearance. Double outlet right ventricle, we see here that the right ventricle, the both are like a U shape exiting from the right ventricle, not one from the right and one from the left. Here is the aortic stenosis. Definitely you can see the left ventricular outflow tract, and at my site of pointing, I have aortic stenosis, and definitely we will have a liaising due to a problem in the flow. Coarctation of the aorta, we know that coarctation of the aorta means that we have a narrow segment of the aortic arch, and it's here, even it looks like interrupted, and we can plot it easier if we don't see it that clear. If I find a right ventricular enlargement and small size left ventricle or left ventricular hypertrophy, that might be an indirect sign that I have a coarctation of the aorta, so I need to spend 2-3 minutes more to look at the mid-sagittal view to see this characteristic appearance of coarctation. Pulmonary stenosis, I said in minutes that the pulmonary artery must be wider than the aorta and must be wider than the superior vena cava. But if you, that's the pulmonary, that's the aorta, and that's the superior vena cava. When you measure the transverse diameter here and compare it to the aorta, you will find that the aorta is a bit wider than the pulmonary artery. So here we have pulmonary stenosis. Dilated left ventricle, definitely we see here pericardial effusion, and the left ventricle, that's the aorta, so that's the left atrium, that's the left ventricle. It's significantly dilated, and we have sluggish contractility. Where here we have hypoplastic left heart syndrome, where we have the aorta here. This is the left atrium, and this is the left ventricle. Only this is the left cardiac side, and this is the right cardiac side. That's always lethal, unfortunately, and the baby cannot survive. Transposition of the great vessels, the ideal plane to check the transposition is through the sagittal plane, when we see the vessels exiting the aorta and the pulmonary moving together along like parallel orientation. And with the Doppler, it's very clear that they are parallel. Supposedly that they should be crossing, but not parallel. So that gives us an idea about transposition of the great vessels, where the aorta arises from the right ventricle and the pulmonary arises from the left ventricle. And here is the axial plane. We can see here, if you look clearly, that's the right ventricular going to this direction and the left ventricular going to this direction. So the both are going towards the same direction, not crossing, and that makes me suspect that I have a TGA. Finally, the tetralogy of Fallot. It's a combination of all the views that I've just demonstrated in minutes. If I have a VSD, I must look for overriding aorta, because it's be placed on this top of this VSD. So here I have 2 out of 4. If I have a right ventricular hypertrophy, then definitely there is a problem in the outflow of it. So I must look for the pulmonary artery. And when I find it lesser in diameter than the aorta, so I have here a pulmonary artery stenosis. So VSD, overriding aorta, pulmonary artery stenosis, and hypertrophy of the right ventricle, all of these make me confident to diagnose tetralogy of Fallot. The pitfalls, maternal habitus and fetal lie can compromise the visualization. Some lesion might be missed. And the take-home message is that, yeah, we know that it's time-consuming to perform the detailed fetal cardiac echo, but there are indications that I've just said, and we kindly need to follow them and do a detailed study of the heart if we have them, and know that a 4-chamber view, outflow tract, and 3-vessel view will be sufficient to diagnose 80 to 85% of the cardiac abnormalities. Thank you so much.
Thank you, Dr. Wael, for this nice presentation. I'd like to ask you about, of course, we know that the fetal echo is a big issue, and it's 15 minutes is not sufficient to go through all the data. What I want to ask is there any obstacles you can view it that in your practice in the fetal echo, that the cardiac MRI with Dr. Hind might solve this issue?
Yeah, up till now, because we're not yet acquainted with the fetal MRI for the heart, fetal heart MRI, we rely solely on the fetal echo. So that's why even if we have some obstacles, we do not ignore, we neglect them, because we have only this modality up till now, up till the current moment. But definitely having the fetal MRI, that's a very big plus actually, and I assume that it's a very promising technique that will add, and even for the cases like the hypoplastic left heart syndrome, where I'm giving a green light to terminate this pregnancy, I might have another support from a different modality that encouraged me to say, yes, that's a hypoplastic left heart, and let's terminate this pregnancy. So the decisive or the cutting off decisions that we must take, the assistance of the fetal MRI for the heart would be a great support to us, definitely.
I think the cooperation with the fetal echo and with the cardiac MRI, we might reach a higher level of diagnosis in the future.
Definitely.
Hoping so. Thank you so much, Dr. Wael.
Thank you, sir. Thank you so much.
Is there any question or inquiry with our audience? Okay.
Thank you so much.
Thank you.